I'm Dr. Meyer, pulmonologist practicing in Sacramento, California. Today's topic is the electronic medical records. A lot has been said about the electronic records, and it's been now the subject of the last two presidents. The last part of Bush administration talked about getting the country and the doctors and the hospitals on the medical electronic records, and now the Obama administration has done the same thing. In fact, the Obama administration convened a healthcare summit in March of 2009 to identify the things that would improve quality of healthcare and control the cost. His flagship proposal was the electronic medical record. He said this would save $80 billion, safeguard against medical errors, reduce malpractice lawsuits, facilitate preventive care, and keep ongoing care of the chronically ill more reasonable. The point of this message today is to point out the value of the EMR itself. It must be pointed out, however, that none of the president's assertions is true. Obama based his proposal on the RAND Corporation of 2005, and there's been no compelling evidence that any of its study points were true. The MR efficiency has been squelched, and if it's so excellent, why there's just a small percentage of doctors using it, and also hospitals, although it's increasing all along. As a group, the healthcare professionals have been on the forefront embracing information technology, and so there doesn't need to be any government support to improve it. And so the reason for the gap has to be understood. The technology problem of the electronic medical record is to maintain it in a small practice setting. Most studies document a reduction in physicians' productivity following installation of the EMRs as opposite from the RAND study. The system generally adds at least a half hour to the physician's day in electronic ordering and responding to false alerts and the things that the EMR generates. Physicians need an electronic medical record, but the electronic record they need does not yet exist. They need a mobile, voice-activated, heuristic, architectural-based system rather than the keyboard and mouse of our present or past technology. Information technology does not require subsidization unless it's not ready for deployment. And it looks like the medical record is just not quite ready for deployment on a universal basis. The business model, the hospital's declining revenues coupled with accelerating capital costs make the investment in EMRs somewhat problematic. In fact, the Alera Health Foundation, an information company serving government and healthcare industry, found it would cost $124,000 for a single doctor or small practice to upgrade to an electronic medical record over a 5-year period. Even though the stimulus for this from the government would be $44,000, it would be vastly under what is required. In 2015, the Medicare penalties start kicking in, and doctors who haven't switched to electronic records will be fined. The initial thoughts of the fine will be about $5,100 a year, less than the cost of the incentive and the cost of installation. In fact, in our own practice, we have all our records on electronically, digitally on the computer, and I can pull up any record I want to and review that. And we also have electronic prescription ordering system, and I can pull up all the records on that. We don't have a total integration, which is very difficult, and that's very hard to keep up, and it's really not present yet. And so our estimate from a consultant we brought into this practice is should we try to go into electronic medical records like many of the doctors that I work with do, who have all had trouble, and after a year or two of having the electronic medical records, they're still having great difficulty in implementing it and adding considerable time to their workday. The electronic medical record was also born because of veracity, to document quality of care. It was also pushed from the centers of Medicare and Medicaid for adequately documentation of the patient's visits. The evaluation and management guidelines of the previous decade provided the excellent mechanism because they fit very nicely into a medical record, and any miscoding, which was to control fraud, and in the process they also criminalize any miscoding, and they cause many more problems into the medical profession. And then a decade later, in 2005, the pay for performance was introduced in the health industry, and the pays doctors, hospitals, and more to meet certain goals were seen as a way of boosting health quality. And the recent advances is that the P4P plans have not affected any achievement of the original goals. And so the RAND study now has done a study, the RAND Corporation has done a study on the P4P programs, and they found that the program appears to have not improved the quality of health care. And so we have lots of unpleasant consequences of the whole proposal of electronic medical records. And one more thing on the veracity of it, it should be noted that it's been shown that there's a lot of errors creeping into it. A professor was asking a medical student about the neurological examination she did, and said that he watched her do it, and she didn't do a neurological examination. She said she just pushed the code for that, and it all printed out. In fact, you can have a very detailed half-a-page neurological examination and not do one part of it. And this has become more common, and that's why the records are gotten to be very voluminous. In fact, just the other day I was asked to review a disability record. There were 16 volumes of records that were over 200 pages. And it was an impossible task to do this in any reasonable period of time. It became so voluminous and laborious that the information could not be gotten, and so we reverted back to the patient to get the details of this. Electronic records is something that we would support, but the evidence isn't there yet that it has arrived. It's still in an evolving situation, and we should allow this to evolve over the next whatever period of time it takes. So long for this week, and we'll be back with you next week to continue the discussion.